forming pancreatic sphincterotomies to cut only the superficial sphincter fibers along the septum rather than a deep cut into the pancreatic parenchyma. This is a patient with severe right upper quadrant pain that is exacerbated by PO intake. Endoscopic ultrasound showed only 3 out of 9 criteria for chronic pancreatitis, which is non-diagnostic, and liver and pancreatic enzymes were normal. She is suspected of sphincter Vodi dysfunction type 3. In this case, you can see a very small papillary orifice. In order to first identify the anatomy, a small amount of contrast is injected to opacify the main pancreatic duct. Here, a manometry cannula is inserted initially into the biliary orifice and then into the pancreatic orifice. The manometry cannula is then carefully withdrawn and pressures are measured, at first the proximal and then the distal sensors on the cannula. Pressure readouts both from the proximal and distal sensors show readings greater than 40 millimeters of mercury. A soft, small diameter wire is then carefully passed to the tail of the pancreas, following the path of the main pancreatic duct as seen on pancreatogram. Again, care is taken to inject enough contrast to identify the main pancreatic duct, however not enough contrast to lead to acinerization. The biliary orifice is quite small and indistinct in this patient. After a pancreatic stent is passed into the pancreatic duct, the bile duct is now cannulated, and a cholangiogram is performed. A biliary sphincterotomy is now performed using a standard sphincterotome. Notice after placement of the pancreatic stent and the cannulation of the bile duct how the papilla seems to grow larger, and landmarks are more identifiable even in this patient with a very small papilla initially. Here you can see a widely patent biliary orifice at the end of the procedure. Cholangiogram at the end of the sphincterotomy shows obvious drainage of contrast, suggesting complete ablation of the biliary sphincter. Here a needle knife is used to perform the pancreatic